Good morning, Chairman, ladies and gentlemen. Next 15-20 minutes would again emphasize and re-emphasize what the last speaker said, that one shoe does not fit all. Two patients with type 2 diabetes in particular are not same. Disease has just been diagnosed and you get him. Disease has been there for quite some time, you get him. Disease has been there for quite some time, has been well controlled. Disease has been there for quite some time, but has not been well controlled, is a totally different issue. Disease is there, long-term disease is there, but there are no complications. Long-term disease is there, but it's complicated. So that becomes a totally different issue. So that it will, a lot will depend. At what stage he comes to you, you happen to handle him. Now, if you look at the way we have been looking at diabetes for quite some time, ever since, I did my postdoctoral studies about 3 decades back. For a good part of 2.5 decades, every time we've been listening, lesser the blood sugar, better. Lesser the postprandial sugar, better. Every time, not only now, for the last few years, we've been talking about quote-unquote glycemic variability. But the data is available for 3 decades. In 1987-86, papers started dropping in. We showed, even if you do not have frank diabetes, depending on what quartile of postprandial blood sugar you have the equal potential to develop coronary artery disease, left ventricular dysfunction. Baraja papers came in mid-80s that a postprandial blood sugar of 120 is better than 140. A blood sugar of 140 is better than 160 and 180. So the basic thought and belief was, as close you get to quote-unquote normal, the better. And that whole thought hold true for a long, long, long time. But the whole thing changed from 2011-12 onwards. And now, thoughts are different. The point is not how close you come to the normal blood glycemia. The point is not how low you get the HbA1c. The point is how well you keep that patient, how long you keep that patient alive, and how long you keep that patient complication-free. It took quite a while to understand that many times in good faith, in order to achieve an excellent glycemic control and a superb hemoglobin A1c, you're causing more damage, you're increasing mortality, you're worsening mortality, you're increasing morbidity. So the thoughts and beliefs started changing for the last few years when from getting as superb a glycemic control, you want to keeping the management giving a good control which is safest possible for that particular individual who is in front of you. Understandably, nobody would deny the fact that we would love to have as good glycemic control and as low a hemoglobin A1c as possible, because there's a direct correlation with microvascular angiopathy, even though a lot of data has not shown its strict correlation with macrovascular disease. But whatever has happened in the recent years, particularly with the publication of some data which shows that intensification of the therapy can cause hypoglycemia and increase mortality. From April 2012, even ADA said, not only that you give a good control, you have to individualize the treatment, and you have to specifically not treat a group, treat the person who is in front of you. And the factors that you keep in mind while formulating the diet therapy, the pharmacotherapy, which are the factors that would determine it? Duration of disease, age and life expectancy. Somebody who gets diabetes at the age of 25 does not have a complication, is a totally different person than somebody who gets diabetes at 65, because the life expectancy is totally different. Additional comorbidities, what else does this individual have? Because diabetes may not come alone. Not only that, whatever comes as a package with diabetes, but an additional disorder that the fellow might have, and particularly coronary artery disease, and if a person has a hypoglycemic unawareness. Now, this is a classical scenario. A newly diagnosed adult has no complication, is overweight. Now, first time comes to you. Understandably, this is a patient population where you would like to achieve an optimal control. Because first time he has come to you, if he is motivated, give him the best possible control. Now here, this is the usual paradigm that you and me would follow. Every time we treat him, either with lifestyle modification or with drug. Global experience has shown, and our experience is no different, that whenever during follow-up you need to see a patient, every time in the natural history of the disease, a time would come when you would have to upgrade the modality of treatment, you would have to give an additional dosage, you would have to add a new drug, you would have to do a collateral support. But more often than not, globally we see that you take a lot of time in making that transition from drug A to drug B, from therapy A to therapy B. And if you want at the end to reduce complications, probably instead of making those decisions here, you need to make those decisions earlier. The classical example is when we plan to give some form of an insulin to a patient. Every time we say, okay, you need insulin. Patient as well as the doctor says, okay, we give a try for another 4 months. So another 3 months, another 4 months down the line, we know on an average we spoil 2 to 3 years. And it's not only a matter of adding insulin, it's a matter of every time from metformin you want to give more complicated therapies. You want to escalate the dose. You want to change the drug that you have been giving for quite some time. So a lot of time is wasted. And in those wasted periods, a lot of glycemic load is put on the body because you get huge periods of poor control. And this is what is happening to most of the individuals with type 2 diabetes. So the basic lesson would be that make the appropriate decision in time so that, these complications can be delayed for whatever time possible. And the bottom line in this class of patients, one would be that this is a class where you would like to have a hemoglobin A1C of 6.5. And the key would be lifestyle, because they have just started diabetes, they are bound to be relatively younger, they are obese, so lifestyle is going. If you put in some efforts in improving their lifestyle, the outcome is going to be reasonably, the effort is worth it. The second group would be the guys who come with recent diagnosed diabetes and are not obese or relatively thinnish. Now, in that class of people, if you look at the global scenario, in the Western world in particular, 90% of the people would be obese. But in the Indian subcontinent, half the people would not be obese. You and me know that. Would not go into the biology of that. But what would this entail? Leaner the person, more the chances that there will be a relatively worse beta cell depletion than in an individual who is relatively obese. And there will be a subset of individuals in this lean so-called type 2 diabetics who would actually end up in having latent autoimmune diabetes of the adult. So their beta cell failure would be quite advanced, and even if initially they respond to lifestyle and some form of a insulin sensitizer or an insulin secretagogue, these are the guys who are going to decompensate very fast and might need some form of a support. And this is what is the classical scenario in the Western world and Eastern world, and particularly in India, that I already alluded to. So in this class of people, the most important phenomena is that paradigm that I showed you, probably those changes will be truncated. Those lifestyle to a metformin, to a sulfonylurea or a gliptin or ABC, and then heading towards insulin therapy. This probably in this particular class, if not in all, but in a significant number of people, that period would be truncated and they might probably, in a relatively quicker period, graduate to need some form of insulin. So that should be another scenario that we need to keep in mind. Now, how we end up actually in making decisions. If you look at this paper that came in Diabetes Care a few years back, after 6 months of diagnosis of type 2 diabetes, 41% have not yet received an appropriate treatment. Even after a year, 1/4 have not received an appropriate treatment. And even after 2 years, some people have yet not received an appropriate treatment. It is not a matter of receiving an appropriate treatment when you make the diagnosis. The same thing happens in your and my practice every time we need to change the diagnosis. That 6 months, 1 year got lost, that I referred to just 5 minutes earlier. So in the long run, adding a glycemic load and whatever that glycemic load entails as a consequence of microangiopathy or macroangiopathy. History of inadequate glycemic control and no complication. This will be a run-of-the-mill patient that walks into anybody's clinic. Diabetes for 2 years, diabetes for 5 years, blood sugar is not controlled. And here you want some semblance of a control. Most of the people would not be diagnosed the same day who walk into the clinic. But they have been hovering up and down, they have been window shopping, they have been doctor shopping, and one fine day walk into your clinic. The reasons for inadequate control: overtly conservative management and delay in introducing different modalities of therapy, already alluded to. 62% would not have at any given time a respectable control in clinical practice. Adherence, a big issue. 62% patients take tablets appropriately, so thereby meaning 40% do not. And most of the people do not have a proper comprehension of what they are taking, at what has to be its relationship is a vis-a-vis food, vis-a-vis timing. 35% recall receiving advice about their medication. It's something like an antibiotic, take a tablet twice a day, take a tablet thrice a day, rather than telling precisely this is the time you need to take a tablet, and then you need to take a diet like this. Practical guide and practical advice to this group of people. Implement a structured educational program. We as doctors, every time, I now realize we have a meeting every fortnight, if not a weekly. We had one last week also my friend and me, Jumani, were there. We have one the next week. If we need to get upgraded, how much do we empower our own patients? Hardly any. We end up in writing a prescription and disposing off. It just doesn't serve a purpose. We're not treating pneumonia or typhoid. So a structured educational program needs to be in place. Now, second class of people, and this is one thing that I've been talking to, that actually ended up in making people believe that you need to customize treatment. Most of the people behave the way they do, the way they take medicines. We behave the way we do, the way we eat the way we eat. So ultimately, a huge chunk of people end up in actual complications. And once a patient comes who does not have an appropriate control, and you already find out that he has some semblance of a coronary artery disease, some semblance of a vascular disease. This is a patient, probably where a lot of water has flown down the Ganges, probably a decade or two have already gone by. This is a patient where you need to be a little bit more relaxed, and you need to avoid hypoglycemia, because we know hypoglycemia is a huge issue every time we try to intensify treatment, particularly in the era of giving MSI therapies, continuous insulin therapies, and sulfonylureas. These massive studies did tell us that we need to be a little bit more careful about that. So not only that, once a person has a coronary artery disease, on the one hand, you have to ensure you give therapies where chances of hypoglycemia are minimal, but also give specific therapies to protect the organ. So you have to intensify the cardiovascular protection. What sort of ACE inhibitors you need, what sort of hypertension optimal control we need, what sort of statins. I've yet to see endocrinologists giving the statins that cardiologists advise. I have myself never written a atorvastatin of 80 milligrams, not even once, or a rosuvastatin of 40 milligrams, when every time a person comes from a cardiologist to me, he has rosuvastatin of 20 milligrams, and I've never seen a cardiologist writing 10 milligrams. So the point is, now the focus changes. Get there. So because if you try to be more sacrosanct with blood glucose alone, it's not going to. And this is the person where you have a significant problem with huge glycemic variability, where you do not only have the huge gaps, but the crashes go into the hypoglycemic range, troughs go into the hypoglycemic range. You need to spend some time with people, educate them, counsel them, and empower them so that they can make their own decisions. Unfortunately, most of us do not have the time, but we have to create systems where somebody is there who has the time to take care of these issues. And probably one important issue would be creating systems where you have mechanism of educating not only ourselves, but our own patients also. 1/3 of patients with type 2 diabetes, we have some data, we have yet to publish it. I was really amazed that one fine morning somebody walks in with a blood sugar of 200 and is very sick. And when I realized this fellow has been having 200, 300 for the last 1 year, 2 years, what brings him to the hospital and to our attention on that particular day? We found out invariably it was a panic episode, it was a depressive disorder, or a functional disorder and anxiety. We documented in 34% of our clinic patients. So it needs to be appropriately addressed. Patient behavior needs to be understood and appropriately monitored. Whatever the glycemic goals, bariatric surgery has come to stay. And there will be a class of people who cannot be helped otherwise, would need to be there. Time is not there to go into the details of that. The summary is, if you look at the total current paradigm of 2015, lesser the comorbidities, lower A1C as low as you can. Longer the life expectancy, a person at the age of 25, you expect him to live another 60 years. Be as good as lowering this as possible. He cannot live for 60 years with a renal failure and coronary artery disease. A newly diagnosed diabetic, put your foot down and make it as good as possible. Established vascular disease or angiopathy elsewhere in the body, shorter the life expectancy, longer the duration of diabetes, you can be a little bit more relaxed. But unfortunately, as I said, most of the times we'll be putting most of the stress here. When people are sick, somebody has renal failure, they look for an endocrinologist or a diabetologist. When things are going well, because patient is not getting sick, but patient is not well, nobody actually pays attention to the things when they need to. So the bottom line is, try to achieve a hemoglobin A1C of 6.5 in individuals, where potentiality and damage because of the hypoglycemia is minimal, and try to be a little bit more relaxed than in individuals, where hypoglycemia is going to be an issue, but concomitantly put in place the secondary support for vascular system, renal, as well as. I strongly believe that the current systems are working. Every time we blame patients, every time we blame systems. But I personally believe we do not have systems in place for handling chronic diseases. So probably we need to have another look at creating systems where we have a multi-speciality approach, not multi-speciality approach only in terms of having a nephrologist there or a cardiologist there. I was really amazed being a part of a session in UK Diabetes a couple of weeks back, where a psychiatrist is inbuilt there, where a psychologist assesses these situations. And I think probably time has come that not only we need to assess patients and doctors, we need to assess the way our systems are working. We need some change there. The bottom line is, we expect a good glycemic control, including early interventions, because they remain the cornerstones. But all these strategies needs to be individualized and customized if we want the best outcome. Thank you very much.